Good morning, everyone. My name is Ahmed Komen and I'm from Kenya. I'm a clinical and radiation oncologist. I'm actually going to talk I'll give an overview of cancer scenes in Kenya, and I will really touch little things about everything because we only have 15 minutes. I couldn't really give a comprehensive detail on what we're doing. But like my other colleagues have mentioned yesterday, we see that cancer causes 7.9 million deaths worldwide each year. Of these deaths, around 70% are occurring in developing world, which includes our countries here in East Africa. And we know from WHO is that if no action is taken, death from cancer in developing world are forecast to grow to 8.9 million in 2030. And the reasons we are seeing this huge number of deaths in developing world is because 70% of cancer patients present late, and most of them present in stage 4. And the only intervention possible is actually giving palliative care, including pain relief. Coming to Kenya, that's a map of Kenya, and as you can see, it borders Tanzania, Uganda, Ethiopia, Somalia, and also Sudan. And Kenya actually has a central government, and now we have what we call county governments. And healthcare in Kenya is now devolved, and all this little demarcation that you're seeing in our map is the counties that are there in our country. And all this healthcare is being a devolved function. All these counties now have powers to put their own budget together and develop their own centers. And this is a good thing in the sense that now we are seeing our counties actually getting actively in management of cancer. And Kenya has a population of 48 million, and we know that cancer affects, according to the latest statistics, 0.1%, which is almost 48,000 every year in terms of incidence. And from latest statistics, we're also seeing approximately 30,000 people die of this disease. And this is approximately 7% of the total national mortality every year. And we still have only two towns, cities in Kenya that has comprehensive cancer services, and that is Nairobi and Eldoret. And these are the only two towns that also has a teaching hospital. And we also see that 60% of Kenyans affected by cancer are also younger than 70 years. And it's the third highest cause of morbidity and death in Kenya after infectious disease and cardiovascular disease. Again, 1 out of 10 children survive cancer in Kenya. This is way, way below most developed countries, whereby we are talking of almost 7 out of 10 survive. So we are really doing badly in that sense. And again, we know that 70 to 80% are diagnosed in late stages. The other thing that is we are moving forward, but a very slow pace, is that we only have one government hospital that offers comprehensive treatment, meaning a hospital that has both that offers both chemotherapy, radiation therapy, and also surgical oncologists are present, and this is only Kenyatta National Hospital. Again, it's very difficult to get accurate national data because most data is coming only from major urban areas, including Nairobi, and now we know that having counties in our country, we are seeing now almost majority of the counties in Kenya now developing their cancer registry, which is a good thing. In the next 5–10 years, I'm sure we will have more accurate data coming from the county level being sent to the national government. So the only data that we have and which is a bit old, is from Nairobi Cancer Registry. And the same thing as Tanzania, we are also seeing in male prostate cancer being the commonest that we see in our place. We are also seeing a lot of esophagus patients, and every week in my clinic, actually, I see almost 2-3 patients with cancer of the esophagus. So it's that common. Stomach cancer is also very common, and now we are seeing less and less of Kaposi sarcoma. In female, again from Nairobi Cancer Registry, it's recorded as breast cancer being the most common cancer that we see in Kenya, followed by cancer of the cervix. But this is always debatable depending on which center that you go to. Some doctors feel that cancer of the cervix is more common, but all the data show that still cancer of the breast is the most common. Looking at the data coming from NCI from 1990 to 2010, most of the developed countries are seeing the mortality going down and numbers of survivors going up. And it's sad that in developing countries it's the opposite. And we are seeing actually rapid rise in cancer cases in our place. And I know my colleague also yesterday, Dr. Furaha, and the reason is because the economy in developing countries is growing, and we are seeing more people, instead of leaving tobacco and alcohol, and many people are using all this, and also infectious causes are becoming more and more common. And also, it's not only cancer, actually. The fact is that most of the non-communicable diseases are on the rise. Coming to the oncology services in Kenya, we actually have almost all specialists in terms of human resource in cancer management. Although our numbers, the number of the specialists are still not sufficient to cover the whole country, but we also have medical oncologists. And we in Kenya now, I think at Kenyatta National Hospital, we have started training medical oncologists, and I'm sure in the next few years we'll have quite a huge number of medical oncologists. We also have radiation oncologists, and most of our radiation oncologists are actually clinical oncologists, in that they're able to give also chemotherapy. In terms of surgical oncologists, we are actually still behind, in the sense that in the whole country, I think we have 1 or 2 head and neck surgeons. We also have quite a handful of gynae oncologists to manage the cancer of the cervix that we are having so many, although we are having Moi University actually now having a program in teaching gynae oncologists. Most of our surgical cases are actually handled by general surgeon, unless the patient is referred to either Eldoret or Nairobi, where we have most of the specialists. We also have a hematology and oncologist. We have also pediatric oncologists, but again, we have quite a few of them, and we also have recognized palliative care to be a palliative care specialist, to be one of the specialists in our, and currently our medical board has actually registered the first palliative care specialist, and this is we welcome that, and we are happy about that, in the sense that majority of our patients are presenting late, and they require their services. Looking at the critical related services to oncology, having said that the healthcare in Kenya has been devolved, it's a really good thing, in the sense now we're having almost all the county hospitals having CT scans, having MRIs, and developing their laboratory to do most of the, especially microscopy, they're able to report. So this is a good thing, in the sense that almost all the county hospitals are able to diagnose cancer and do their staging. Coming to laboratory, we still depend on a few labs that are located in the major cities. That is mostly Nairobi and Eldoret, because they have a teaching hospital, and we are able to do most of the test. We are still not yet on molecular. I know yesterday our colleague from Burundi was talking about development, but we sent our samples through these laboratories, and they are sent outside the country, and we are able to get the results and use those results to manage our patients. Looking at the radiotherapy services, which I think is of interest in our group here, like I said, we only have one government hospital giving these services, and it's Kenyatta National Hospital. And most of the patients who require government services, especially radiotherapy, are sent to Kenyatta National Hospital. We have Moi Teaching Hospital, which is yet, and they have been planning for the last almost 10 years to install their radiotherapy services, but it's yet to materialize. But we hope in the next year, they are hoping to install their first linear accelerator. We also have we have also the other centers, which are all privately owned, and they're the ones actually that treats most of the patients in the country. We have Texas Cancer Center. They offer just external beam radiation therapy, and the rest of the hospitals, private hospitals, are able to give, they have linear accelerator machines, and they are able to give external beam. They have brachytherapy, and now most of our patients in private are treated with a minimum of 3D conformal radiation therapy. At HCG, CCK, they're able to do IMRT techniques, which is slightly higher for select sites, and also at Aga Khan University hospitals, they're able to give, they're able to do IMRT technique. So this is a plus for head and neck cancers, prostate cancers, and others. So in Kenya, in terms of radiotherapy services, we still rely on private sector to provide this service for our patients. And this has been possible because now the government, through National Hospital insurance funding, patients are able to access using their cards and get this treatment. In private, they just top up just a little. What is the Ministry of Health doing about all this? There's been tremendous progress from 2012 until today. They are committed, we can see, to reducing cancer mortality. There's been several policies that has been published by the government, including National Cancer Control Registry. We have Cancer Prevention and Control Act. And most importantly, I think in 2016, there was establishment of National Cancer Institute of Kenya, which actually now is mandated to advise the Cabinet Secretary, collect and analyze research data, collaborate with partners, disseminate information, and support treatment facility and also training. And lately, which was published just last year, we have also documents from the Ministry of Health on National Cancer Control Strategy 2017-2022. Like I mentioned again, National Hospital Insurance Fund has played a great role in terms of helping our patients access both treatment and also investigations. And initially, like I mentioned, most of the counties now are having their own cancer registries. So these are all work in progress, and we expect to see fruits in the next 5-10 years. In conclusion, we actually, all of us have a role in terms of improving cancer care. Cancer crosses disciplines, and we all have a role in doing that. Just to close, there is an African proverb: to go fast, you go alone; to go far, we have to go together. Thank you.